Meaning what, guys? Let's say I take my phone out. Okay. Let's say I want to click the photograph of the whole room I can see. That means the area of view has to be larger. If I want to click a few photograph of the whole room, then the area visualized has to be larger. For the area to be larger, I cannot zoom my camera. Can I zoom my camera? No. That means area is dependent on the magnification. But if I want to click only the photograph of my eye, let's think about it. If I want to click the photograph of only my eye, then I will have to zoom onto my camera. That means I will have to increase my magnification. If I increase the magnification, the area of view will become small. You understand? Okay. So basically the area visualized is opposite to the magnification. You understand? The smaller the magnification, the larger the view. The more the magnification, the smaller the view. So now we go back. In direct ophthalmoscopy, the magnification is 15 times. That means the magnification is high. If the magnification is high, the area visualized will be, I can say, smaller. But in indirect ophthalmoscopy, the magnification was only 3 to 5 times. That means the magnification is small. For the small magnification, the area visualized will be larger. The area visualized will be larger. Okay, everybody? Now, how to answer this question? A. If the area visualized is smaller, you understand this point? Yes, sir, everybody, thumbs up. Do you understand that in direct ophthalmoscopy, because the magnification is up, this area visualized will be small? Okay. So because the area visualized is small, if I look at the fundus, I will only be able to look at the central part of the fundus. I hope you understand. Yes. Because I'm only able to look at the small part, I will be only able to look at the central part. But because in indirect ophthalmoscopy, my area becomes larger, I'm already able to look at the center, but along with the center, I'm also able to look at the periphery. So I will say central plus peripheral fundus. Central plus peripheral fundus. Or if I answer it in another way, I can say central fundus means I can only look at the central part of the retina, optic disc and macula. As I just shown you a photograph in the beginning, the photograph of the central fundus, we are able to look at the optic disc and then through the blood vessels, the macula. But in indirect ophthalmoscopy, because I can see the center, I can see the optic disc and macula. But because I can see the periphery, I can also look at the ora serrata if I want. I hope you understand this. I can also look at the ora serrata if I want. Or if I try to put it in simpler words for you, the field of view is 10-degree field. And here the field is almost around 45 degree. This is my angle. Or if I measure the area will be equal to 2 dd, and here the area will be equal to 8 dd. Okay, everybody, done. So smaller area, larger area, just presented in various different ways to you. Okay, please just try this. I take a 1 minute break and I'll come. I just have some water and I'll come back, guys. 1 minute break. Okay, guys, so sorry for the break. Just had some water and I come back. I hope you have written the differences between direct ophthalmoscopy and indirect ophthalmoscopy in terms of area visualized. Because the area visualized is small, it is central fundus, optic disc and macula. The field of view is small, 10 degree. The area visualized is 2 dd. Larger central plus peripheral, because it is peripheral plus ora serrata, larger field, larger area. Okay, everybody. Now moving on, some other differences between direct ophthalmoscopy and indirect ophthalmoscopy that you should know is direct, indirect. Okay, stereopsis. Stereopsis. As I've explained in squint, stereopsis means depth perception. Stereopsis means depth perception, and depth perception is a function of binocular vision. Stereopsis means depth perception, and depth perception is a function of binocular vision. Now, if you understand this, I ask you, stereopsis is present or absent for direct ophthalmoscopy? Stereopsis present or absent? Yes or no? Stereopsis, direct ophthalmoscopy, yes or no? Everybody, see the instrument. Stereopsis, yes or no? Stereopsis, yes or no? I'm showing how to do it. Stereopsis, yes or no? Anybody who can answer this? Stereopsis, yes or no? Stereopsis, yes or no? See my eyes. See how am I examining it? I have closed one of the eye. Through the other eye, I'm keeping the instrument in front of me and I'm examining the patient's eye. Stereopsis, anybody? Stereopsis, anybody? No? No? Okay. You have mixed answers. Majority of you are wrong. Majority of you have answered stereopsis is present, but actually stereopsis will be absent. There will be no stereopsis. Why there will be no stereopsis? As I just tried to explain to you, if you saw that I hold the instrument in one hand, I close one eye, and through the open eye, I examine the patient's eye. Okay, that means I use which vision? I use which vision? Do I use binocular vision or do I use uniocular vision? When I'm doing direct ophthalmoscopy, I use uniocular vision. Because I use uniocular vision, my binocular vision is absent. Because my binocular vision is absent, my stereopsis is absent, and thus I can say there is no stereopsis for direct ophthalmoscopy. But now let me again show you indirect ophthalmoscopy. When I'm doing indirect ophthalmoscopy, I wear it over my head. This lens, this area, everybody, this comes in front of both my eyes. See, both my eyes are open. See this, everybody. See this. This has holes for both the eyes. Yes. So I am able to look from both the eyes at the patient. I look at the patient from both my eyes, everybody. Yes. So I am using which vision, everybody? I am using binocular vision. I am using binocular vision. So because I am using binocular vision, I say stereopsis will be present. Yes. Okay, everybody. I hope you understand. If you understand how to use this. Now the next questions are also in use. Direct ophthalmoscopy. What is the position of examination? Direct ophthalmoscopy. What is the position of examination? The position of examination is basically standing or sitting. But the position of examination for indirect ophthalmoscopy has to be supine. Has to be supine. Okay. Done, everybody. Then after the position of examination, what is the distance of examination? Anybody can type in the answer here, everybody. What is the distance of examination? What is the distance of examination? Anybody? That means how far do you do the examination from? Direct ophthalmoscopy is done from what distance? Nobody. So direct examination or direct ophthalmoscopy is done as close to patient as possible. Whereas indirect ophthalmoscopy is done from a distance of roughly, we say, arm's length. We roughly say arm's length. Okay, arm's length. I hope I'm clear here. I hope there is no confusion in this, and that's all about my ophthalmoscopy references. Again, I think I told you everything that I could. If I was teaching a clinical class, that means if I was probably in a posting and teaching you, I would have shown you how to do ophthalmoscopy with a patient along with it. Obviously, this is not the time to do this. But yes, after I finish this complete ophthalmology course in May, in June, I will take a course on clinical techniques in which I will be showing you clinically along with the patient of how to perform each examination with a bird's eye view. Right, guys? So after we finish this complete course, though this should be necessary for all of you, specific indications. That's what I'm asking you guys. That should be common sense now. So I'll be asking you this actually. Okay. Now, so I ask you. Let's say there is a patient of papilledema. Let's say there is a patient of papilledema. Which ophthalmoscopy will you do? Option A, direct ophthalmoscopy. Option B, indirect ophthalmoscopy. This is very simple common sense answer. Anybody can tell me. Papilledema. Papilledema. If you have seen my neuroophthalmology lectures, you know papilledema means edema of the optic disc. Optic disc. So almost all of you have answered it correctly till now. I have not got any wrong answer. I'm so happy. I'm so happy nobody's answering it wrong. So all of you are correct. Mitul, Meet, Argash, Sarat, Ash, Shubhajit, Doshi, Swati, Mayank, Saurabh, Ishwar, and Ajay. Very good, guys. All of you have answered correctly. The answer is direct ophthalmoscopy. Very good, guys. Brilliant, guys. Okay. So the answer is direct ophthalmoscopy. Now, why did you do answer direct ophthalmoscopy? Because direct ophthalmoscopy gives you a more magnified view of the optic disc. Yes. So optic disc can be seen in both direct and indirect. But when you only want to see the optic disc, you will want a more magnified view. So that's why you have gone with papilledema. But if I ask you, which investigation will you do to examine retinal detachment? Again, both the same options are there: direct ophthalmoscopy or indirect ophthalmoscopy. Now, what will you answer through your common sense? If there is retinal, Meet, Sarat, Mitul, Ash, Saurabh, Swati, Arga, right? You're answering quickly, guys. Jinal, you're also right. Doshi, Ishwar. Everybody is right, guys. Everybody again is right. I hope you understand this. Retinal detachment can occur anywhere in the retina. Retinal detachment will not be restricted to the central part of the retina. It can occur near ora serrata also. That means for a case of retinal detachment, you need to actually examine the center as well as the periphery. Because you want to examine the center as well as the periphery, you will need to do indirect ophthalmoscopy. You will need to do indirect ophthalmoscopy. I hope I'm clear about the indications. So the indications are common sense actually. Whenever you need to examine only the optic disc of the macula, you prefer what have you said, direct ophthalmoscopy. But when you want to examine the whole retina, we prefer peripheral indirect ophthalmoscopy. Done, everybody? That's about our first investigation of ophthalmoscopy. Now I will move on to the second investigation that I will discuss with all of you as part of retinal investigations, which is FFA. The full form of FFA is fundus fluorescein angiography. Fundus fluorescein angiography. Fundus fluorescein angiography. Okay. Now, fundus fluorescein angiography. What is the thing that we understand from the name? From the name, we understand that we are doing angiography. Angiography basically means blood vessel visualization. Yes, of the fundus by injecting a dye. What is the name of the dye now? Fluorescein dye. You understand? So we are examining the blood vessels of the fundus by injecting the fluorescein dye. Now, what is the color of the fluorescein dye? The color of the fluorescein dye is orange. The color of the fluorescein dye, everybody, is orange. Am I correct, everybody? Where do we inject this dye? This dye is injected in antecubital vein. Don't say in the retina or in the eye or intravitreal injection, guys. We inject in antecubital vein. Okay, it is injected in the antecubital vein. From the antecubital vein, it will go to my eye. Okay, everybody. It reaches around after 8 to 12 seconds. It will reach. Okay, then we will shine light, and then the dye will have fluorescence. Do you understand the name of the dye? Fluorescein. Fluorescein is the name of the dye because it gives some fluorescence. Fluorescence means shine, or if I say chamak. जहां जहां डाई जाएगा वहां वहां चमकेगा. If you understand this, are you clear? Wherever the dye goes, that part will have fluorescence. That part will shine. Am I clear? Now, क्या चमकेगा? What will shine? Where is the dye going? The dye is going in the blood vessel. So that means the dye is staining the blood and the blood vessel. So all the blood and the blood vessels will be fluorescizing or shining. सारा खून चमक रहा होगा, सारा blood vessels चमक रहा होगा. Am I clear? Now, before I go on to image and I try to explain this, I'll just do a very simple thing. What is the side effect of FFA? Side effect of FFA is orange colored urine. Please remember, it's not a complication, it's not a contraindication, it's just a side effect. You have to inform the patient about this before doing FFA, that for 2 to 3 days your urine will be much darker in color, much orangish in color. There is nothing to worry about. We expect that, so the patient doesn't come running to you or to some other doctor that, oh, my urine has started becoming orangish, I got jaundice or whatever. So this is something that you need to explain to the patient. For at least 2 days this will occur, orange colored urine. Now, through an image, I'll try to explain you FFA if you understand this much. Everybody, let's try to understand FFA now through an image. So this is a normal image of FFA that I have posted on the screen for you. This is a normal FFA image. This is a normal FFA image. Now, what do we see? First of all, let's see the basic anatomy. This is my optic disc. I hope you can see all the blood vessels are coming from here. Blood vessels are forming a loop on this side. That means this becomes my temporal side. This becomes my nasal side. On the temporal side, I see this area. This area is avascular. So that means this becomes my fovea or this becomes my macula. First of all, we see the basic anatomy like always. Now I see what is shining. I see that the blood has stained my arteries and my veins also to a degree. Yes. All the blood vessels, veins, artery, capillaries, all of them are stained by dye. Yes. That means the dye is entering the blood vessels. There is blood in the blood vessels and it is fluorescizing, it is shining. Okay, that means all the blood vessels are normal here. What do I mean to say by normal blood vessels? What can be abnormal? If there was leakage, everybody understand? Let's say there was a hemorrhage, then the dye would have pooled here. I hope you understand. Yes, this green color, the dye would have pooled here. Then I would have said that there is some blood leaking from the blood vessels. That is why the dye is also leaking from the blood vessels. Or let's say it was a case of CRAO, central retinal artery occlusion. Let's say the occlusion was present at this point. If the occlusion was present here, there would have been no dye after the occlusion. You understand again? So we are trying to judge vascular pathologies. We are trying to judge vascular pathologies through my FFA, which I say in simple words can either be leakage or blockage. There can be various things called pooling, masking, everything. I'll come on to it later. Basically, you understand. Either the blood vessel can be broken, hemorrhaging, leaking dye, or it can be blocked, so no dye. But here we see there is nothing like that. There is neither any leaking, neither any blocking. Now, what is the second important thing we have to see in this diagram? If we focus, we see that the macula is black in color, or the macula is dark. We see that the macula is dark. Now, the macula is dark. Why? The macula is dark. Why? If I ask you in simple words, the macula is dark because we already know the macula is avascular, or the fovea is avascular. Because the fovea is avascular, there are no blood vessels. Because there are no blood vessels, there is no blood. Because there is no blood, there is no dye going. Because there is no dye going, there is no fluorescence. Because there is no fluorescence, there is no shine, and the macula remains dark. Am I clear, everybody? So that means in FFA we can have two items: vascular pathologies and macular pathologies. Do we understand this, everybody, guys? Again, do we understand this, everybody? Vascular pathologies and macular pathologies. I'll just bring up 2 or 3 photographs for you on screen, and I'll try to show you the abnormalities which can be seen. Everybody, let's see this photograph now on the screen for all of you. Everybody, is this a normal FFA or an abnormal FFA? Question: normal or abnormal? Everybody, normal or abnormal? I hope you understand this as an abnormal FFA. You can see this blood vessel. Everybody see this blood vessel? Yes. Along with this blood vessel, you see all these areas where I am circling black. All these areas are of hemorrhage or leakage. Yes. Simultaneously, you can see all these areas. Can you see all these areas? Can you see all these areas? See all these or all these areas? What do you see? Dots, very small dots surrounding the blood vessel. Very small dots surrounding the blood vessel are microaneurysms. If you don't understand it now, I will make you understand later on. Microaneurysms, outpouching of blood. So there was a blood vessel, there is an outpouching. In that outpouching, more blood is being collected, and that is why it is appearing like this white dot around the blood vessel. Am I clear, everybody? Microaneurysms. You can also see one more thing here, everybody. See, there is one more important thing that I'll show you here. If you know a little bit about your retinal science, see this green box. What do we see in this green box? There is a blood vessel going. Around that blood vessel, there is this butterfly-shaped tortuous blood vessel forms. This is neovascularization. This is neovascularization. There are new vessels being formed around the normal blood vessel. So basically, we see 3 damages in the blood vessel on FFA. I hope you understand how we understand vascular pathologies. I'll bring up another photograph on the screen for you for your better understanding. Okay. If I can find it, okay. This is the image that I wanted to bring up. Everybody, let's see again on the screen, please. The diagnosis is written. I'm not interested in the diagnosis. See this blood vessel, everybody. Can you see this blood vessel is filled with dye? See this blood vessel. This blood vessel is also filled with dye. But now see this blood vessel, everybody. Look at this blood vessel. What do you see in this blood vessel? That this blood vessel is just filled up till here, then it is blocked. Due to the block, there is no dye after it. That means it is the case of blockage. That means it is also an abnormal FFA. Do you understand? All this blood vessel is empty. There are 1 blood vessel, 2, 3, everything is completely filled, but this blood vessel and all of its branches are empty. Done, everybody? And that is why this is also an abnormal FFA. So this is abnormal vascular FFA. So I hope you understand how abnormal FFA works in terms of vessel. Now, if I bring up the last image for you on screen, how to see the vascular pathologies, I'll just show you a simple image. Everybody, I don't want the diagnosis again. I don't want your diagnosis. I just want you to know whether it is normal or abnormal right now. Okay, everybody, again, see, this is my optic disc. These are my blood vessels. So this is my temporal side. That means this is my macula. My macula should have been dark, but there is now some leakage at macula. I hope you understand what I'm trying to teach you here. Yes, the macula should have been a completely dark area, but now there is some leakage at the macula. Because there is some leakage, that's why I can infer that there is some kind of problem at the macula. The area which is supposed to be dry and dark because of the vascularity, there is some kind of fluid appearing there. If there is some kind of fluid, it may be CME, cystoid macular edema. I don't know. It may be CSR, central serous retinopathy, but there is some leakage at the macula. That is why it is abnormal FFA. Okay, everybody. So that's how you find out macular pathologies and vascular pathologies on FFA. When I do teach you the pathologies later on, I will keep bringing on these photographs again to explain you each pathology. Okay, and that's all about my third investigation. My third investigation is everybody FFA. Okay, now moving on, guys. Let's move on to the second investigation was FFA. Third investigation, everybody. Third investigation is ICGA. The full form of ICGA is Indo-Cyanin Green Angiography. Indo-Cyanin Green Angiography. See, again, it is also angiography. But now what is the dye? The dye now is Indo-Cyanin Green. So the difference which has occurred is actually in the dye. The dye is now Indo-Cyanin Green. The dye is now Indo-Cyanin Green. Am I clear, everybody? The dye is Indo-Cyanin Green. Now, what is the use of Indo-Cyanin Green angiography when we already have FFA? So it is better than FFA for choroidal circulation visual. Choroid. Yes. So we also can see an FFA for choroidal circulation visualization. It is better than FFA for choroidal circulation. Please remember, fundus means retina as well as choroid. Yes. So we also can see any choroidal pathology, but for choroidal pathology, the better angiography is Indo-Cyanin Green. Why is the question? Because of 2 reasons. Indo-Cyanin Green is 98% protein bound. So there is less leakage of the dye. So it has more retention in the large blood vessels. So because it has more retention in the large blood vessels, choroid which contains large blood vessels, I can see it. Then secondly, it is 98% protein bound. So there is less leakage of the dye. So it has more retention in the large blood vessels. So because it has more retention in the large blood vessels, choroid which contains large blood vessels, I can see it. Then secondly, it is better because it fluoresces at, okay, it will also have some shine, okay. So it fluoresces at 805 nanometer. So the wavelength of light for its fluorescence is larger. So we say it has better penetration. Okay, so longer wavelength light can fluoresce it, so it can penetrate deeper structures also, and that is why we say it is better than FFA for choroidal circulation, which is a deeper circulation compared to the retinal circulation, right, guys? But what we need to know, what we need to understand is a very important side effect. The side effect is that this dye contains iodine, so this is contraindicated in patients with iodine hypersensitivity. Okay, with iodine allergy, Please remember this very simple point. but it is contraindicated in patients with iodine allergy because the dye contains 5% iodine. For any choroidal pathology, this is better. Just remember this. That's the basic thing that we want to get across. Okay, done. That's the third investigation. Nothing much to discuss in this. Now let's move on to the fourth investigation. So the fourth investigation that I'm discussing is known as OCT. The full form of OCT is tomography, optical coherence tomography, OCT. Now I hope all of you know tomography, CT scan, computed tomography, radiology, guys, CT scan. So basically, if I say in short, this is the CT scan of eye, OCT, optical coherence tomography, CT scan of the eye. Okay, everybody. Now, what is the principle of OCT? Again, CT scan principle. I hope you know. So the principle of OCT is it uses low coherence interferometry. Low coherence interferometry. Obviously, infrared light is used for CT scan. So that infrared light is having low coherence interferometry. We say that bones can be seen on X-ray, and we say that bones can be seen on X-ray, and bones can also be seen on CT scan. CT scan also show you soft tissue, but soft tissue can also be seen in MRI, or soft tissue can also be seen on ultrasound. Basically, yes, soft tissue ultrasound, bone X-ray. If we can see soft tissue on ultrasound, why do we do CT scan over an ultrasound? Soft tissue can be seen on ultrasound. Why do we do CT scan? We do CT scan because CT scan gives us slices. Slices means it shows us the structure of an organ in terms of the layers. Ultrasound does not show us the structure of an organ. It just shows us the organ. Okay. Yeah. So that means this layer is retinal pigment epithelium. That means this layer is retinal pigment epithelium. That's why I've written here. The outermost layer RPE is red in color. Okay. In very basic language. That is the first thing you find out. As soon as you find out this, you know now that this is your choroid and this black area is your vitreous. Okay. Now, what do you see? You see that this is your complete retina. But in this area, you see that there is a depression. Why is this there a depression? Because this is not an abnormal area. This is your fovea or foveola. As I mentioned a little while back, at the foveola, inner nuclear layer, ganglion cell layer are absent. That basically means the inner layers are absent, so only the outer layers are present. Yes, this is a normal variation. These are the outer layers, inner layers are absent. That's why I've written again. Fovea appears like a depression. That is a normal funda. That on an FFA, fovea appears like a depression. Do you get this point? Do you get this logic here, everybody? Yes. Still, if you want to see it more, look at these two nuclear layers. You can see, everybody. Can you see this yellow colored layer? Yes. Can you see this blue colored layer? Sorry. Can you see all these nuclei, everybody? Similarly, can you see this dense blue colored layer with all these nuclei, guys? This is your inner nuclear layer. This is your outer nuclear layer. I hope you understand this. Okay, everybody, if you want to look at it. Done, everybody? So these are just simple ways through which you can find out the FFA. Now, when an FFA picture comes to you in your exam, will they ask you to identify the layer? Never. They will ask you to identify the pathology. I'll show you two photographs. And I'll ask you to differentiate between them based on what I've shown. First, let's see this photograph. Everybody, forget what is written at the bottom of the screen. What do you see in this? You see this is the red colored layer. That means this is retinal pigment epithelium. Now in this area, what do you see? That the whole of the retina, starting from the first layer to the 10th layer, is detached. So all 10 layers of retina are detached. Can you make it out, everybody? All the 10 layers of retina are detached. But if I bring up another photograph for you, and I ask you the same question, let's see whether you are able to make out. Now everybody see the next photograph which I'm bringing up on the screen. Sorry. Now in this area, everybody focus on this area only. In this area, how many layers are detached? Are all 10 layers detached? Yes or no? Are all the 10 layers detached? Are all the 10 layers detached in this area that I have drawn? Yes or no? That's the simple question. Yes or no, guys? I don't know who is answering the question, but whosoever has answered the question has answered it correctly. Somebody has answered it wrongly also. Okay. 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 So majority of you answered that no, all the 10 layers are not detached. If you try to look at it carefully, this is my RPE coming, this is my RPE coming, this is my RPE coming. My RPE is still present. Only the 9 layers have detached. Neurosensory retina detachment. And this is which place? This is your subretinal space, if you remember. Yes. So this is your subretinal space. Neurosensory retina detachment, subretinal space. This was my normal retina. Sensory retina detachment. Am I getting again? See the images. See this, all 10 layers detached. Now see this, only neurosensory retina detachment. So this is what FFA or OCT enables. Sorry, OCT enables us to do. In both the cases, there is retinal detachment, but we don't know whether the complete retina is detached or only neurosensory retina is detached. Clinically, both of them will present similarly. So in such cases, we need to do our OCT to be able to diagnose. I hope you are clear about this case, and that's all about our investigation. OCT. There should be no confusion in this. This is the normal OCT. This is abnormal. This is also abnormal, right? So now let's move on to investigation number. Sorry. Okay, done. So now let's move on to investigation number 5. USG. B scan ultrasonography. Okay, B scan ultrasonography. I hope you understand through radiology that ultrasonography can be A scan, B scan, C scan, or M scan. There are lots of types of ultrasonographies, right? So here, what we are using everybody B scan. If you have seen my session on lens already, in lens I've already taught you one type of ultrasonography, A scan. A scan ultrasonography was used to calculate the axial length of the eye. Yes, everybody. This is B scan. What is the full form of B? The full form of B is brightness scan. Brightness scan ultrasonography. This is the most common ultrasonography that you know of. Calculate the axial length of the eye. Yes, everybody. This is B scan. What is the full form of B? The full form of B is brightness scan. brightness scan ultrasonography. This is the most common ultrasonography that you know of. If you've ever seen an ultrasound of the abdomen in pregnancy, all those scans are B scan ultrasounds. Okay, we use 7.5 to 10 megahertz ultrasound probe. Okay, everybody. So they ask you this, everybody. So please remember, in this we use 7.5 to 10 megahertz ultrasound waves or an ultrasound probe. Done. Now, what does an ultrasound work on? Ultrasound works on echos. Ultrasound works on echos. So when we do ultrasound, the sound waves go inside, they touch each structure, and they form an echo bag. Again, I will bring up a photograph, and then through that photograph, I'll try to explain you this. Okay, let's see this photograph, everybody. Okay, nothing much, nothing difficult here, everybody. Let's quickly do it. Everybody, let's see this image. In this image, does it look like an ultrasound? I hope yes. Everybody, ultrasound, whether an abdominal or whatever, this looks like an ultrasound. From the ultrasound, we are trying to examine the posterior segment. So now we should know that in the posterior segment, first of all, there is vitreous. And vitreous is completely black cavity. If you know your radiology, all the structures which do not have echos, okay, absent echos, they appear dark, or I can say black. And we call those structures anechoic. So I can say my vitreous is anechoic. If I want to study like a radiologist, or if I want to study like an ophthalmologist, simply I will say vitreous is black in color. I will say vitreous is black in color. Am I clear, everybody? On ultrasound B scan, vitreous appears black in color. Then I will go to this image. Here, everybody. What is this, everybody? This is retina first and then choroid. Yes or no? Behind the vitreous, there will be first retina and then there will be choroid. First of all, there will be retina. So this will be my retina and then this will be my choroid. Retina and choroid both have echos present. Okay, everybody? Echos are present. When echos are present, it appears white. We call this area hyperechoic. Okay, when we call this area hyperechoic, we now know retina and choroid are white in color. Please do remember that on a normal B scan, vitreous is black in color and retina and choroid are white in color. Hyperechoic, anechoic, or hyperechoic. Okay, I prefer black and white. Now, why am I telling you this black and white? I'm telling you this black and white because when we see an abnormal B scan, all we need to see is whether the abnormality is in the black area or whether the abnormality is in the white area. Just to show you an example, guys, I'll bring up a photograph on the screen again. So just for an example, photograph, tell me where is the problem. Is the problem in the black area or the white area, everybody? This is your, I just bordered it for you. This is your black area. As soon as I border it, I should hope it should be clear. And this is your white area. So what do you see? A tumor-like condition has grown in the white area. Yes. So there is a tumor in white. Tumor in white. That means there is a growth or tumor in either the retina or the choroid. Are we clear about this here, everybody? This is not a problem of the black area because this is a white growth along with the attached white area. Yes. This is a tumor choroidal melanoma. How do we know it is not a retinal tumor? This is a characteristic shape. This is called mushroom-shaped tumor. This is called mushroom-shaped tumor. And mushroom-shaped tumor is characteristic of choroidal melanoma. You understand what I'm doing? I'll show you another photograph to be able to differentiate, guys. Now everybody see this photograph. What do you see in this photograph? Do you see any abnormality in the white area? See, the white area is absolutely completely normal. The vitreous, which should have been black, has now developed some white things in it. So now the pathology is in which area? The black area. Because the pathology is in black area, I know the pathology is in vitreous. And through the given other symptoms and signs, I will be able to find out that this is a vitreous hemorrhage. Blood is also hyperechoic on ultrasound. Okay, everybody? So this is vitreous hemorrhage. That is how we use our B scan. So again, I will be very simple. To remember B scan, please remember black vitreous, white retina, and white choroid. Then just see where is the lesion, whether the lesion is in the retina or in the choroid, that is white area, or whether the lesion is in the vitreous, that is the black area. That's all I want you to be able to do here. Right, guys? Done. Now I move on to my next investigation. So my next investigation is a simple investigation called as ERG. The full form of ERG is electroretinography. Electroretinography. ERG. Now from the name, what do we get to know? Electroretinography. ERG. That means there is some kind of an electro. Electro means what, everybody? Electro means some kind of an impulse. Yes, current impulse coming from the retina. Retina means retina, which we are recording and plotting a graph. Okay, everybody? So we are forming a graph of the impulse which is coming from retina. If in simple words I try to say it, retina is producing a potential impulse. Retina is producing a potential which I'm recording on a graph. Now retina, when does retina produce a potential? Visual pathway. Whenever light falls onto the retina, retina produces a potential. Action potential. Ganglion cells are the first site of generation of action potential. Yes. So I can say ERG is the record of action potential of retina. Now, what is the graph like? So the graph looks like this. Simple. One negative wave, everybody. Then one large positive wave, and then one very small positive wave. This is my baseline. So if I say there are three waves, the first wave is called as A wave, the second wave is called as B wave, and the third wave is called as C wave. Now they ask you a simple question. A wave generates from which cell, B wave generates from which cell, and C wave generates from which cells. So A wave is the wave of depolarization which starts in photoreceptors. B wave is generated by Muller cells and transmitted by bipolar cells. This is slightly tricky, everybody. See, bipolar cells themselves do not generate any wave as far as ERG is concerned. Along with bipolar cells, we have neuroglial structural supporting cells called Muller cells. So actually, Muller cells generate this B wave, but Muller cells are not present in the visual pathway, so they can't conduct this B wave. So the conductance of this B wave is done by bipolar cells. Now, C wave, everybody. C wave is generated by cells of retinal pigment epithelium. This denotes basically the activity of metabolism. The metabolism activity that is occurring in the pigment epithelium, that is generating the small wave, and that is called your C wave. Okay, everybody. So three simple questions: A wave, B wave, C wave. You can get an image-based question, identify the wave, or they can mark an arrow on any of the waves A, B, and C, and then ask you from which cells does this wave generate or get produced from. And everybody, that's A, B, and C wave. That's a normal electroretinography. Now, there are some special types of ERG. Special types of ERG. The first special type of ERG that we all should be aware of is called as multifocal ERG? This question was asked in AIMS 2015 May. I think May attempt AIMS 2015. This question was asked. The question was multifocal ERG. Multifocal ERG generates responses from which cells? Multifocal ERG generates responses from which cells? The options were cones, rods and cones, or pan-retinal. This was the question. If anybody knows the answer, feel free to answer. I am waiting for 30 seconds again. I've started the poll. Multifocal ERG generates the responses from which cells? Okay, I got one answer. Anybody else? Okay, I've got a lot of answers now. Anybody else? Anybody else? Very good. Keep on marking, guys. Very good. Okay, keep on marking, guys. Very good, very good, very good. Brilliant, guys. Keep on marking quickly. Okay, I'm still waiting, guys. Nobody has given me the correct answer. That's the beauty of the question. That's why it's a names question, guys. Okay, multifocal ERG, even though it is multifocal, the answer is it generates responses only from cones. It generates responses only from cones. That's the answer, guys. Okay, multifocal ERG generates responses only from cones. I hope I'm clear here. Okay, not going into the detail. Generates responses only from cones. Okay, done. Now, secondly, there is another thing called as ERP, early receptor potential. Early receptor potential. Okay, this is also generated only by cones. It is also generated only by cones. Okay, then there is another special type of ERG which is called as pattern ERG. Pattern ERG generates from ganglion cells. Okay, it generates from ganglion cells. Because it generates from ganglion cells, that is why we say it tells us about the integrity. I can say it assesses the integrity of optic nerve. It assesses the integrity of the optic nerve. As we just discussed in the basic anatomy, optic nerve is the same as ganglion cells. Axons of ganglion cells are forming the optic nerve. Okay, everybody. So pattern ERG generates from ganglion cells. That's why it assesses the integrity of optic nerve. That's about your ERG. I'll quickly take up the last 5 minutes to finish your investigations. The seventh investigation is EOG, a very simple investigation, that is electrooculography. Electrooculography. Okay, everybody. EOG, electrooculography. Now, see again, graphy means graph, electro means impulse, oculo means eye. That means the eye is generating an impulse which I'm recording on a graph. But the eye can generate an impulse even when it is closed. The eye can generate an impulse even when it is closed. When it is closed, it is not doing any work. That means there is no action potential. That is the basic difference between EOG and ERG. ERG was a record of action potential, whereas EOG is a record of standing potential. EOG is a record of standing potential of eye. Okay, EOG is a record of standing potential of eye. Okay, it reflects the activity of RPE, that is the outermost layer, and photoreceptors. That means basically only the two outermost layers of the retina. Okay, so it reflects the activity of pigment epithelium and photoreceptors, outermost two layers. So EOG can only be used to determine the diseases or the pathologies of the outer two layers of the retina. Okay, now how do we measure EOG response? How do we measure EOG response? So EOG response is measured by something known as Ardens ratio. Ardens ratio. Ardens ratio is light peak upon dark trough, and normally this is greater than 1.85. Normally this is greater than 1.85. Light peak upon dark trough. Ardens ratio. I just explained it to you, everybody. I just explained it to you. What do you mean by light peak upon dark trough? Basically, we do EOG under two conditions. One is light condition, one is dark condition. And when we do it in dark condition, we record EOG. Whatever value of EOG we get will be variable. Okay, whatever is the least value, trough. You understand trough? So let's say if I get a graph like this in my dark condition, so this will be my least value, trough. This will be dark trough. Then let's say I get this kind of a graph in light, so this will be my topmost. This will be my light peak. You understand? So the highest value in light and the smallest value in dark. I will divide both of these. I will be known as Ardens ratio, and this value should normally be greater than 1.85. That's all. Okay. If it is less than 1.85, as you would see in the diseases to come, we will say EOG is abnormal and it will diagnose some disease. But whatever disease will be diagnosed will be either a disease which will be localized to the pigment epithelium or localized to the photoreceptors. Okay, everybody done. So that's all about investigations which are usually done in retina. I have gone into explanation of the basic investigation of thermoscopy, of the most commonly done investigation FFA, of the investigation that is OCT and B-scan. ERG, EOG, and ICGA, you don't need to know in detail. That's why I'm not going into very detailed explanations of that. But whatever pathologies we will now be discussing later on in our later sessions, all of these will use some of the other investigations. I hope you will be able to wrap your head around these investigations in the next half an hour that we have a break. So basically, this is like a big session with a half an hour break. My next session starts from 12:30. From 12:30, when I pick up